Well, hello everyone. I'm Daniel Rodriguez Munoz, one of the electrophysiologists at University Hospital 12 de Octubre in Madrid. And thank you for being here. Thank you for your interest in this topic. We are going to talk about the SWEET-cryo strategy, which is a strategy aimed at fluoroscopy reduction during cryoablation of atrial fibrillation that we have developed in our center. Very briefly, we're going to talk about why this is relevant, what we achieved with this strategy, and finally, the most important part, how we implemented this strategy in order to achieve the results. So we'll start with the why, and we're not going to stop too long at this. Just basically, this is a summary of the fluoroscopy times reported in randomized clinical trials comparing radiofrequency with cryoballoon ablation for PVI. There are many other studies, prospective, retrospective, observational studies, but just to focus on a few ones, and in terms of the robustness, we thought it was more interesting to report randomized clinical trials. And we see that from 2014, the core trial, to just a couple of years ago, the RAISE-AF trial, we have seen a decline in fluoroscopy times both in cryoballoon ablation and radiofrequency ablation of atrial fibrillation. But this progressive reduction has found a plateau, probably, in cryoballoon ablation stays at around 13, 15, 17 minutes, while radiofrequency ablation has achieved even further reductions in fluoroscopy exposure, around 5 minutes, 7 minutes, or even less than 5 minutes in other studies. So basically, cryoballoon ablation has inherited for many years now this handicap of, yes, it's a technique that's equally effective, it's equally safe or comparably safe, but one of the main drawbacks of the technique is that it requires the use of longer fluoroscopy times. Now we thought that it was not necessarily true, and the results, I'm going to start by the end of this, the results that we obtained, you can see them here. We have summarized in this graphic representation our experience that you can see on the right end of this panel, compared to other studies specifically focused on fluoroscopy reduction in cryoballoon ablation of atrial fibrillation. Now, these other studies have explored different techniques. Some of them, you can see them here, have opted for the use of intracardiac echo for electroanatomic mapping during the procedure, and achieved significant reductions in fluoroscopy time. You have also the comparison of how fluoroscopy times were for those operators or in those centers before applying these strategies and after that. In general, you see this very marked fluoroscopy reductions. Now, of course, there's one drawback of using intracardiac echocardiography, which is, well, you complicate a little bit the workflow of the procedure, first, and second, you increase the cost, which may be a problem in some healthcare systems, in some settings, due to reimbursement capabilities, etc. Now, on the right hand of the panel, you see our experience, and we divided our experience, and you'll see the design of the study, in the experience of a senior consultant, in this case that was me, and the experience of a fellow in training, of a second-year fellow. And we thought this was important mainly to observe the applicability of this strategy even to operators with a bit less experience, or even, as you see, operators in training. Now, what we saw was what you can see here, that mean fluoroscopy time for the senior consultant was slightly over 2.5 minutes. That is a 6.7-fold reduction with respect to what was my fluoroscopy time, my average fluoroscopy time before, immediately before. And for a fellow trainee, it was slightly over 6 minutes of fluoroscopy time, mean fluoroscopy time, compared to over 30 minutes of fluoroscopy time before. Now, that is almost a 4-fold reduction. We talk about fluoroscopy time all the time, but it's also important in terms of optimizing the use of X-ray and the radiation exposure for both the patient and the operator, to think of the dose area product. And you see that in our cases, using just the same settings of the same fluoroscopy in CINI settings, the dose area product for a consultant came down to 11% of what it was before, and for the fellow in training was 17% of what it was before. I think the results, both in terms of comparison with other strategies that have been reported so far without an increase in cost, and in terms of the relative reduction to what was our common practice before applying the strategy, are very promising, very interesting. Now, you have some more data, and these are data that are currently submitted for publication. And you see the design of the study that we carried out. We compared a retrospective cohort of consecutive patients right before starting to apply the strategy with the consecutive patients enrolled during a 16-month period, and follow up for an additional 18-month period. So the minimum follow-up that we have for the last patient enrolled was 18 months, and the average is, as you can see here in the Kaplan-Meier curve, around over 30 months for the intervention group, and over 40 months for the comparison for the control group. Now, what you see on the right-hand side, just very briefly, there were no significant differences in terms of the outcomes of the procedure acutely. No differences in the rate of complete pulmonary vein occlusion, no differences in terms of adverse events. That may be one of the aspects that we could be concerned about. If we're using too little X-ray, are we risking the patient? Are we assuming an inadequately high higher risk of complications? That was not the case. We didn't observe that. And what you see as significant, of course, is the reduction in fluoroscopy exposures. Also, additionally, and maybe because of the application of a systematic workflow, we saw a reduction in total procedure time and left atrial dwell time. This is not the aim of this strategy, but probably was an effect of the observation of the operators knowing that we were being observed, or even the application of a very well-established workflow protocol. Now, we also wanted to see if this reduction, if these fluoroscopy times were sustainable after the end of this study, because of what I just mentioned. During the study, you know that you're being observed, and you probably tend to overperform. When you're not being observed anymore, what happens with that? So during the 18-month follow-up period, we selected 10 random cases to explore what we had been doing afterwards. And the results that we obtained were those. You can see fluoroscopy times, and you can see dose area products. You see that 60% of the procedures are below 2 minutes of fluoroscopy time. The rest are between 3 to 4 minutes. One that was especially complicated was slightly below 10 minutes of fluoroscopy time. Now, how do we do that? That's probably the question that you have more interest in answering. Well, this is the protocol. I won't stop step by step because there's a very common steps where you have this, and you can take a look at it more slowly afterwards if you want. But this is what we marked ourselves, what we considered would be reasonable to achieve in every step of the cryoballoon ablation procedure. We believe there are certain parts of the procedure where we were using fluoroscopy before, and we found that there was no need. For instance, during resheathing of the cryoballoon catheter into the sheath, we don't need that. We have the markers in the catheter. We have, in order to know when the spiral diagnostic catheter is completely retrieved into the sheath as well, we have the noise that appears in the electrograms. So we analyzed every step, and we thought, well, do we really need fluoroscopy in this step? And if we do, how long would it be reasonable to confirm that we are doing what we aim to do? That the catheter and the sheath are moving the way we expect them to, that we are occluding the vein properly, that we are able to register electrograms inside the pulmonary vein, etc. So our theoretical goal was to have fluoroscopy times ranging between 1 minute 40 seconds in a procedure where everything goes well, everything is easy, and up to around 7 minutes if we are on the higher end of the fluoroscopy time required for every step of the procedure. You can see that this relates quite well to both the mean fluoroscopy times that we had in our study, and also the individual fluoroscopy times that we observed in the 10 randomly selected cases during the follow-up period. Now, how do we do it? We have some videos for you. We always systematically do femoral venous puncture with echo. In terms of, we believe that is almost mandatory nowadays in terms of safety and preventing the most frequent complication, which is due to vascular access. You see that we have already, when we step on the X-ray pedal, we aim to have already the catheter, the diagnostic catheter, on the right atrium, as we do, for instance, and we have that experience from zero fluoroscopy procedures. And we also try to progress the guide wire into the superior vena cava. After that, we progress, you see that already, our transeptal sheath over the wire. We don't step on the pedal constantly, but just rather confirm whether with single images, whether the sheath is already in the superior vena cava. Of course, we use constant fluoroscopy during the positioning of the catheter for transeptal puncture. I didn't mention it before. We don't use additional media for transeptal puncture, not intracardiac echocardiography or transesophageal. During transeptal puncture, of course, during the puncture, we use constant fluoroscopy. Once we have punctured, we progress the sheath over the puncture, over the needle. We progress the guide wire into the left atrium, aiming to place it on the left superior pulmonary vein. Once we have done that, we, as you see, we move back and forth the sheath in order to dilate the transeptal puncture, so that passing the flex cath sheath will be easier. The exchange of the sheath doesn't require, again, constant fluoroscopy exposure, but just only single images to confirm how far up we are with the sheath. You see that we are now exchanging the sheath, putting it inside the patient, and we progress it. See that I'm not stepping on the pedal, just single images to make sure when I get to the right atrium. See that I'm entering the right atrium there. We enter the left atrium, we progress it slightly, and now I aim to place the sheath already on the ostium of the left superior pulmonary vein, so that when I insert the catheter and the cryoballoon catheter and the achieve catheter, I will already be in the left superior pulmonary vein, and I will be able to guide my movement not only or not mainly relying on fluoroscopy, but relying on electrograms and the marks that we have on the cryoballoon catheter that tell us when the catheter has exited the sheath. Okay, I'm going to pass to you see that we are flushing the sheath to avoid any bubbles coming in or clot formation. The rest of the procedure I'm not going to describe. It's a very standard procedure. We use a heparin bolus, of course, to achieve an activated clotting time of over 300 seconds. We flush the sheath and we will progress the cath. You see that we have already massaged the balloon to remove any bubbles. And again, I'm not stepping on the pedal. I'm not using fluoroscopy to know when I am exiting the sheath. I know it because of the marks that you know already are on the cryoballoon catheter. Now you see that I take it to the first mark, so that the balloon is not yet outside of the sheath. Now I retrieve the sheath so that I expect the sheath to be in the left atrium and the balloon to be right at the ostium. I inflate, I position the balloon, and then you see that I'm going to try to obtain electrograms. You see them appearing now in channels 5, 6, and 6, 7. And I'm going to inject contrast. I'm not stepping on the pedal while I inject contrast, but right only afterwards to see the effect. The vein is occluded, so I start the application. Okay, this is the standard initiation of the procedure. We don't have the timer here. I think the total time of this of the cases that we recorded was in the 3 cases. We recorded 3 cases. I think it was in the 3 of them around 1 minute 30 seconds, 1 minute 40 seconds. They were nice cases, easy cases. And generally, we aim to be doing the first application in the left superior pulmonary vein at around 40, 50 seconds before 1 minute of fluoroscopy time. That's the ideal situation. Okay. Now, the next thing we do is when we pass from one vein to the other. And you see that we finished an application. This is another case. We finished the application. We want to resheath the catheter. Oh, no. This is an example of repositioning before that. An example of repositioning in the left inferior pulmonary vein. And you see that I'm not stepping constantly on the pedal when I am giving more torque to the sheath or more deflection. I'm just doing the movement, and then I step on the pedal, single image, to check that what the system, what the sheath and catheter did is what I expected them to do. Okay, so I'm not constantly using fluoroscopy to observe real time the motion of the sheath and the catheter. Okay, that's an example of repositioning, as we saw, and this is what I was telling you before about an example of resheathing after this application in the same vein. And you see that I'm not using fluoroscopy to see what I already know is happening. The catheter is coming inside of the sheath. I know that because of the markers on the catheter, and then I retrieve the spiral catheter, as you see, until I have noise on the proximal electrodes 7 and 8. Which means, when I move from one pulmonary vein to the next, I want to have my cryoballoon catheter inside the sheath, but I want to have my achieved catheter outside of the sheath so that I will prevent potentially hurting the endothelium of the left atrium. Just to know that this is the position in which my catheters are, I don't need fluoroscopy. I just need the markers of the catheter to know that the cryoballoon catheter is inside the sheath, and the noise in the proximal electrode of the achieved catheter to know that the proximal electrode is just inside the sheath, but the rest of the catheter is outside. Now, for phrenic nerve pacing, we aim to obtain a position without the use of fluoroscopy. As you saw before, I introduced a deflectable catheter in the coronary sinus for reference during the transeptal puncture. I remove it without using fluoroscopy to take it to the inferior vena cava, and then I try to progress it to the superior vena cava without deflection and without fluoroscopy. If I find some resistance to the progression of the catheter, of course, I step on fluoroscopy. I don't want to risk anything. I look at the catheter where it is, I maneuver, I handle it into the superior vena cava, and then I am pacing. I'm trying to obtain stable phrenic nerve capture, but I generally don't need fluoroscopy for that. I know that I'm moving the catheter. I know what the catheter is doing, whether I need to go further up or a bit lower down. I don't need to see the response to torque in most cases. I just need to see that the patient has phrenic nerve capture and to stabilize the catheter there. Now, transition between veins, as you saw after resheathing, I check that the catheter is where I want it to be, especially in inferior veins. I don't want the catheter to go into the left ventricle, and I do the motion that I need. In this case, I do clockwise rotation with while maintaining a deflection of the sheath to pass from the left inferior to the right inferior pulmonary vein. In most cases, and you probably know that from your experience as well, you feel this jump of the catheter when it has entered the right inferior pulmonary vein. I progress the spiral catheter, the achieved catheter, and I observe the electrograms. In this case, I did use a little bit of fluoroscopy. As you saw, single images or very short-lasting images to confirm that we are where we want to be. In some cases, you can even give it a try without using fluoroscopy. Just an image to confirm that the deflection of the sheath is approximately 90 degrees when you, before moving from the left inferior pulmonary vein, clockwise rotation, feeling that jump, and then progressing the achieved catheter. And if the achieved catheter registers pulmonary vein electrograms and then progressing it a little bit more, they disappear. You know that you are in the right inferior pulmonary vein in a high percentage of the cases. Now, right inferior pulmonary vein, we all know that that's commonly challenging anatomy. So sometimes we may need repositioning. We progress the achieved catheter, we progress the cryo balloon. We don't need, again, fluoroscopy to know that both catheters are inside. We inflate. We don't need fluoroscopy to know that the balloon is inflating. We know that it's inflated. And now we're going to try to position the spiral catheter. You see that I'm not using X-ray. I just want to see that I have electrograms. I inject contrast. It's occluded. So we are going, and for that we used a total of 3-4 seconds maybe of fluoroscopy time in the right inferior. Of course, there are many times right inferior pulmonary veins that are more challenging, that require more repositionings. But in this case, if you keep in mind that for repositioning you don't need to be looking at the motion of the sheath and the catheter constantly in real time, but just single images to confirm the position, you drastically reduce fluoroscopy exposure. Finally, the motion from right inferior to right superior pulmonary vein, and that's probably, agree with me, that's probably the easiest, or one of the easiest steps. We are going to resheath the catheter as you saw before. We eliminate the deflection of the sheath. We progress the achieved catheter and maybe a little bit of clockwise rotation if needed. And you see that without fluoroscopy, we know that we passed from the right inferior to the right superior pulmonary vein. I'm going to play the video again. It's a short one. Look at the electrograms. You see we start having noise, so we know that the spiral catheter is at the tip of the sheath. We start having electrograms as soon as we remove the deflection of the sheath. We progress the catheter, we have electrograms, and we lose them. We know that we are in the right superior pulmonary vein. Okay, so that's a strategy. I hope that you find this useful. For us, it's been a game changer in terms of the fluoroscopy exposure that we offer our patient, but very importantly also ourselves. Many of us do over 100 or even hundreds of cases of cryoballoon ablation per year, and we have many years of EP career ahead of us. The difference between doing 15, 18 minutes or doing 2-3 minutes as an average in our procedures is huge. If you think about the whole duration of our careers. So I encourage you to give this a try. There's no increase in contrast. There's in cost, no increase in contrast, of course. There's no increase in complications, no decrease in effectiveness, and it's doable. You saw that also for fellow trainees. It's an applicable workflow. So thank you to Medtronic for offering me the chance to present our data and our experience, and thank you for your attention.